Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics seminar series. My name is Andrea Bianchi, and I'll be the moderator for today's session. Our speaker today is Dr. Michael Gordon, and this seminar is entitled Late-Stage Dementia, Providing Comfort, Compassion, and Care, Clinical and Ethical Issues. So before I introduce Dr. Gordon, I'd like to let you know that this seminar is being recorded. This lecture, along with other archive lectures, can be accessed through the Joint Center for Bioethics YouTube page. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. And now I'll offer a land acknowledgement before jumping into the formal introduction. So I certainly wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and I am grateful to have the opportunity to live and work and play on this land. So now it is my pleasure to introduce today's speaker. Dr. Michael Gordon, born in the United States, graduated from the Faculty of Medicine at the University of St. Andrews in Scotland. He traveled widely and did postgraduate training in the UK, US, Canada, and Israel. He came to Canada in 1973 and took a position at Baycrest Geriatric Centre and Mount Sinai Hospital. He was awarded the first certification by the Royal College in Geriatric Medicine. He also obtained his Master's of Science at the University of Toronto through the Joint Centre of Bioethics. He finished his career at these two institutions in 2019, and he was awarded the status of Emeritus Professor. He continues to write articles and books and presently works at the Toronto Memory Clinic, and he also continues to teach in the Family Practice Program at Baycrest Geriatric Centre. So Michael, on behalf of the Joint Center for Bioethics, welcome to today's seminar, and I'll allow you to take it away.
Good. Thank you very much, Andrea. It gives me great pleasure to speak at the Joint Center because my master's that I did part-time at the Joint Center was one of the best experiences and decisions of my life because in many ways it changed my career from being a clinician and administrator to getting into this, at that time, relatively new world of ethics and with a special focus on the elderly. So the goals and objectives are to address the clinical, ethical, and educational challenges that face healthcare providers, healthcare trainees, and families for those living with late-stage dementia, and explore some contemporary new dimensions in this area of care. Now let's look at the problem. In industrial nations like Canada, we face a rapidly aging population. Even with new advances, diseases for which treatments have been developed, ultimately there is a terminal phase, especially acknowledged with malignant disease. And the reason I use the concept of terminal phase, because it wasn't that long ago that we would characterize diseases as terminal. And if you had cancer, for example, they often said, you have a terminal disease. Well, we now know that many diseases, including many cancers, and I'm an example because I responded very well to a malignant blood disease, and I haven't gone into the terminal phase. So we have to think of these diseases as having a timeline that may eventually go into terminal phase, but because you have the diagnosis doesn't mean you're in the terminal phase. So terminal phase is not always considered with conditions that cause dementia, but must be properly considered to plan care. And much of the focus on dementia until relatively recently has been to diagnose and treat. Now, for those who know the field, the current pharmacological treatments are at best symptomatic or modestly delay progression. But we now have some newer medications that you've probably read about that may actually change the whole nature of diagnosis and treatment with the idea of early diagnosis and potential interventions that may change the biochemical dynamic. And that may have a major impact in the future, although we're not there yet. And we also have to remember, especially in Canada, but not exclusively, the cultural variations in population often affects how we care for people who suffer from cognitive impairment dementia. So the medical treatment for dementia right now include improving cognition and awareness, and we have various interventions, some of which are medication. We would like to decrease the rate of progression. We think some medications may do so, and we've now learned more and more that many lifestyle activities can be beneficial. One of the challenges is controlling behavioral problems. And for those who've actually looked after someone in the family with dementia, you realize these can be the most challenging. And then we have to remember, and this is especially for those of us in the care of the elderly, rather than, for example, neurologists who focus on the brain, treating associated conditions, which often include nutritional deficiencies, swallowing disorders, and the ability or inability to function in their activities of daily living. Now, there are many non-medical treatments which we have to focus on, and that's support and education for caregivers, improve the milieu of life, and that's a big challenge. And you often hear people say, oh, the best thing is aging in place, staying at home. But I can tell you, for many people, that means they become prisoners of their home or almost hermits, because, and we learned this a lot during COVID, people became isolated sometimes for long periods. We want to provide as much quality as possible for those who have a progressive disease. And we have to look at all kinds of ancillary modalities, like how can you improve the actual activities of daily living and living arrangements. And then one of the most important things, and for those of us who are in the world of ethics, preparing patients and families for the end. And in the memory clinic I work at, as part of my initial evaluation, after I find out who has the power of attorney for personal care, I discuss with the patient, however competent or incompetent they may seem, the issue of artificial nutrition and hydration, because that's one of the most challenging. And the family often says they never had the courage to ask the question. And they were almost surprised when the person said, why would I want that? And I said, you've got the answer now, because when it happens, you're not given a lot of time to think about it. So when I was in training, and I trained in Scotland, and I graduated in 1966, so I probably graduated before most people in the audience were training or even born, we didn't even use the word dementia. I mean, Alzheimer's disease had been described, but it was in a young woman who probably had one of the unusual causes of dementia. And we often use the term senility, which of course just means old. And I tell you, for those of you who know Scottish accents, they would often say, oh, Dotty, she's just a wee bit dotty, right? She's off. She's a wee bit dotty. And it wasn't really even thought of as a medical condition. Now, over the decades, and I watched it happen, there was a gradual recognition that it's a disease entity, and it has various pathologies: degenerative Alzheimer's, PICS, frontal temporal, Lewy body vascular mix. It's a very complex issue. So the concept of senility or even dementia has many facets to it. So we now recognize it as one of the great challenges of modern society. Many articles are written on the societal costs, the impact on families. There's now a big emphasis on detection and diagnosis. We're really learning about what the merits of markers are for earlier and early diagnosis. And that is only important if you know you can do something about it. Some of the things that we recommend are really generalizable. You don't have to have a diagnosis to follow a possible, probable, healthy lifestyle, because we know it's good for the heart. We now have more and more evidence that it's good for the brain. And you don't need the diagnosis to do it. You don't have to wait. In fact, you shouldn't be waiting for the diagnosis to do that. So what are the concerns in society is the perfect storm. For those of you who saw the movie The Perfect Storm, you remember what a disaster was. Increased aging population, increased prevalence of dementia, legalization of physician-assisted or MAID suicide, and the impact on society, families, the healthcare and long-term care system. Now, some years ago, the Alzheimer's Society, which if you haven't been involved with it, is an unbelievable organization. It's in North America and Canada, I think elsewhere in the world. And they did a very good report called The Rising Tide, in which they looked at all the aspects of dementia and Alzheimer's during that period. And basically, without having to be an epidemiologist or a graph hotshot, you know that any curve that is going up with age and it represents a disease is not good. So you could see that the prevalence of dementia is going up, and it's going up more than females than males. Now, there was a study done a number of years ago, 2015, which was quite a remarkable study. And as I mentioned earlier, where we started to recognize a lifestyle. So this was a Finnish story, a 2-year multi-domain intervention of diet, exercise, cognitive training, vascular risk monitoring to prevent cognitive decline in at-risk elderly, and it showed a significant decline. In fact, the benefit was as good as any drug we have. But for any of you who've tried to change your lifestyle, you know it isn't easy. I, for one, have struggled all my life with issues related to weight, diabetes, and I know how hard it is. And even though I'm a doctor, I needed a doctor to basically order me around. Now, fortunately, she had been one of my residents, so I knew how good she was. And we said, Michael, it's about time you did this. I said, you're right. Now, this year, in the Canadian Longitudinal Study on Aging, which is one of the highly recognized worldwide studies on aging, which has been going on, I think, for about 20 years, 50% of dementia cases in Canada could be prevented or modified by altering 12 risk factors across the lifespan. And that includes activity, hearing loss, and obesity. Now, hearing is very interesting because I used to frame it as following when people would say, I don't remember things, and they had hearing impairment. I said, well, if you didn't hear it, you can't remember it. But now there's studies to show that actually poor hearing, it's almost like exercise. You're not stimulating the neuronal connections in the brain that from the auditory system. So we now, for those of us in practice, always make sure that whatever else we're doing, we make sure we optimize a person's hearing. That may be hearing enhancement with hearing aids, or sometimes simpler things that are much cheaper, like what we call a pocket talker, which is really a little self-contained amplifying system. What do you do? Well, if you want to follow what was just said in 2 studies, keep doing crosswords, Sudoku, learn a foreign language while you're running on a treadmill and eating broccoli. That's the recipe. Now, obesity may be associated with increased risk of developing dementia, and that was shown in the English Longitudinal Study on Aging. And it shows that if you're overweight, that increases the risk. Maybe, which is interesting, Ozempic, which I am taking for diabetes, and we're not prescribing it on the ODB for obesity, maybe that's a bad decision, because obesity is a major risk factor for dementia. And it may be that it becomes a standard drug for those who struggle. And it's not because they're the puritanical view, they're gluttonous. For those of us who've struggled with obesity all our lives, know that we don't suffer from moral turpitude, because there's something in our biology that makes it difficult for us to control portion size, etc. And in the same way that we give people antihypertensives for high blood pressure to prevent the outcomes 10 and 20 years down the sides, it may be that drugs in the family of Ozempic, because there's a whole bunch of them coming out, because once a new drug comes out, everybody's going to genericize it and copy it and then the price comes down. So here's a couple of case studies. 82-year-old female, patient of Baycrest complex continuing care for a year, mixed multi-infarct Alzheimer's. She has a PEG, right? A feeding tube inserted prior to transfer from a general hospital. She's stable. Now the family wants to remove the tube. So for those of you doing ethics and you're working in hospitals, I'm willing to bet you've had a couple of cases like this where they call you in because there's conflict. So the family says she never would have wanted to be like this, and we put in the tube because we hoped she'd improve. And although the staff understand the position of the family, they have great difficulty carrying out the request. They have what you often call moral conflict, right? They feel as if they're doing something wrong. So the physician says, I won't write the order. for moral and religious reasons. Now, that raises a whole other issue. And one famous ethicist that I remember hearing a lecture said, when you walk into the room, you leave your personal values at the front door, because that may not be the values of the person you're dealing with. So another physician writes the order, but there's a great deal of turmoil among the staff. So what are the options? And if I were in a lecture hall and I could see you all, I'd say, well, do you just stop the feeding tube? Do you do a quick in-service to the staff? Do you have the family speak to the staff about their reasons? Well, because there was turmoil among the staff, the decision was made to transfer the patient to the palliative care unit, because when they were asked, they said, well, of course, we do this for a living. And within 10 days, she died, she went into coma, and the family were forever grateful because they realized what they had done. They had never talked about it, was not doing their mother a particular favor, because she was really never tasting any food anymore and really lying uncommunicative. Now, when we debriefed the staff of the original floor, they bemoaned the fact that they had not heard directly from the family why they had made their decisions. So here's another situation. 93-year-old female admitted to Baycrest directly from a hospital in Florida. Now, that's pretty hard to do, but this was, you might say, the good old days when we could do it. She had a previous stroke with a good recovery, some progressive cognitive decline, but able to enjoy many aspects of life. She looked after by a personal support worker full-time. She was in Florida for the winter in her own condominium, and while breakfasting, the PSW turns from the table for a few moments. She turns around, and the patient's blue and unresponsive. She calls EMS, cardiac respiratory arrest. They do CPR. Now, of course, when they did it, that's like doing what we used to call a Heimlich, although you can't call it that anymore. Because when you do CPR, you're doing the equivalent. So the food was expelled, but she had been really unresponsive for many minutes. She survived, but in Florida hospital, she never recovered consciousness, and they put in a peg, a feeding tube. So she was directly admitted to transfer, minimally conscious state, otherwise stable. After a few days, the family presents us with a living will. They said they didn't know it existed. They said it was never discussed, and it was in a safety deposit box. So I can tell you, when you're speaking to families and you say you have a living will, you don't put it in a safety deposit box. You let everybody who's involved know about it. I know where I have mine, and there's instructions to my family. We've spoken about it, where to find it if somebody says we need to see the document, which is really not necessary. It states quite clearly that she would not want artificial feeding. Now, artificial feeding only means one thing. It doesn't mean you're getting Chinese food when you normally like Italian food. It means you're getting food in a way that's not your normal way of eating. So there's a family meeting with the senior staff and the ethicist, which at that time was me, informed son and daughter that it would be our duty to respect the mother's clearly stated wishes and cease to use the PEG, according to the Healthcare Consent Act, which all of you should know back to front. The family refused. They said she could not have understood what she was signing. So they are already diminishing their mother's autonomy, assuming that for some reason, when she did this, she couldn't understand what she meant. So it became very contentious. Consent capacity hearing, which, if you haven't been to one, it's a very good experience. And the panel agreed with Baycrest. The family appealed to the Superior Court of Ontario, and that appealed with the family, agreed. So the decision was made by Baycrest to not appeal further. I mean, I guess you could go up and up and up, but you have to decide which battles to fight. Clearly very meaningful for the children that they did not let her die. They could not live with it themselves if they did. And she was in a minimally unconscious state for 1.5 years. She got outstanding nursing care, and she died of natural causes. Now, if that meant the family could live with themselves, maybe you'd say that was the right thing to do. But in terms of respecting the person, the mother, that's questionable. So here's another 89-year-old male European immigrant Holocaust survivor. Now, when I worked at Baycrest, we had many, many Holocaust survivors. So this person moved into a retirement facility attached to a long-term care facility after the death of his wife. Over 3 years, gradual and progressive cognitive decline resulting in moves to parts of the facility that provided increasing levels of support. He developed increasing behavioral problems with wandering, emotional outbursts, disruptive behavior, despite some modest improvement with medications. And then he had his first episode of aspiration pneumonia. He was treated in the connected complex continuing care hospital with antibiotics, and he had a severe delirium. And he recovered, and this was followed by one infection after another, pneumonia, urinary tract infection, and he was becoming increasingly uncomfortable. So the attending physician outlines possible diagnoses and further tests, some of which would require transfer to a general hospital. Although Baycrest had a lot of resources, there were certain things we couldn't do on site. But the family wants to understand what's the prognosis and treatment for his agitation and discomfort. The physician expresses reluctance to give him potent opiate analgesics or neuroleptics because she says, I don't want to hasten his death. Now, this is even though the family said, we'll accept that. So there was a gradual decline in function, no oral intake, and the family refused the feeding tube because they felt that's not what their father would want. So the question is, should the physician search for treatable causes of decline? Is it worth putting the person through CT scans, MRIs, etc., GI studies? Is there a good reason to withhold opiates? The person's expressing discomfort. How about neuroleptics? If you give them opiates, is that going to hasten death? There used to be a belief that giving opiates decreases respiratory function and hastens death. And the evidence became, with good studies, that it did the opposite. That in fact, people who got the opiates for pain lived longer than those who were deprived it and were dealing with pain. And can the physician be charged with euthanasia by giving opiates in this situation? Now, again, if I had sight of the participants, I could ask you to raise your hand. Well, the death occurred after a week of decline with evidence of significant discomfort. And the family, who included a number of healthcare providers, expressed dismay about the reluctance of the physician to provide more robust palliative care interventions, including adequate doses of opiates and maybe neuroleptics for agitation. So let's look at the challenges of aging. The success in aging has led to a viewing of these aged individuals successful in their efforts as a burden to society. You see articles all the time in the media, in the papers, on television. They used to say bed blockers, as if the person lying in the corridor wants to be there, just to punish everybody. This is especially the case of frail elders suffering from dementia. And I can remember when I used to do a call from Mount Sinai emergency room, I get called in the middle of the night by an intern or resident, always with an apology. I'm sorry to wake you up, Dr. Gordon. I just got a 88-year-old person from so-and-so nursing home who's been admitted because she's very confused. I'm really sorry to bother you. What should we do? And of course, what you do is, why is she confused? And very often it was an infection. And unless there was a reason not to treat the infection, there was a reason to treat the infection. And many got treated and went back to the nursing home for a period of time. If it happened once after another, then there was another discussion to have. So what are the implications for the care of the elderly? Well, clinical, what are the interventions that are suitable? Multiple chronic medical problems. Economic, what is society prepared to spend on the care of the elderly? And who will pay for it? Now, depending on your society, there may be limits. And in some societies, being elderly is not particularly a good thing to do unless you have a lot of money. And in countries such as the United States that don't have universal healthcare systems, there are problems. At least in the United States, Medicare does allow many things to happen for the older person that cannot be accessed by younger people. And Medicaid does the same for older people who are below a certain economic level. And the other thing is, what are the ethical impact? Because some say how you treat the older person really is a reflection of the fabric of your society. And then the educational, are we preparing our trainees? And that's trainees in all the domains: medicine, nursing, social work, physio, OT, etc. You know it. And having now been a patient because of serious illness, I've been around that block, and I can see how people are treated, including me, and how wonderful it is when the people treating you actually care and know what they're doing. So what should be our goal? Well, first, to continue to provide the means to decrease illness and disability. When we tell people to be vaccinated, I've heard people, the conspiracy theorists who say it's all to put money in the doctor's pockets. They get a kick. I've heard people tell me you get a kickback for every vaccination you give, which of course is absurd. But look at the vaccine denial that goes on. We're now having outbreaks of measles, much less COVID, or influenza, increased life expectancy at all ages, but a special what we call active life expectancy. You have to make a decision. If you can provide another 3 years of life to somebody, but the life is miserable, uncomfortable, unproductive, unsatisfying, is that a good 3 years? Or if you can do something to provide 1 good year, is that a fair trade-off? Well, if you ask people, they may opt for the 1 good year. And very important, and this is societal, improve our value of the aged, irrespective of the level of function. And this is an integral part of the community. And it's very interesting to see how there's been an evolution of implementation of enterprises and policies to improve the function and accessibility of older people. The whole idea of accessibility is fantastic. I mean, I can remember where if you were in a wheelchair and you had to go from a sidewalk to the road, you had to go down the curb. Well, now by policy, every curb has a place where you can move a wheelchair. And that makes a big, big difference. And of course, the best important is provide care in a humane manner. Now let's look at dementia. For those living in dementia, it's a reflection of society's view of its members. If we abandon affected patients and offload increasing levels of responsibility to families, we will undermine our societal and caregiving mandate and give a clear message to our societal values. And this is very important. And depending on the structure of where you're living, in which jurisdiction, whether a lot of the effort is expected to be picked up by families and on their nickel, on their cost, as opposed to societal collective, really is a reflection of society. I spent a lot of time because I trained in Britain and I also worked in Scandinavia to see what societies provide as part of their universal public healthcare systems and the range and quality of their long-term care system. So if we do not accept, recognize, and communicate as healthcare professionals that most of the causes of dementia have a terminal phase, we will fail to provide proper palliative care to those in great need. They and the families will suffer unnecessarily. And because of my recognition of this, I wrote a book, which has the name of this title, because I had a conversation with somebody and I mentioned something about dementia. And they said, oh, that's a terminal disease. And this is somebody I thought who knew better. I said, it's not a terminal disease. You could get a diagnosis of Alzheimer's and live for 10 years, 5 of which are pretty good. My father died at 99. He had 9 or 10 years worth of the diagnosis of dementia. And only in the last 3 years was he really impaired, but he still enjoyed things. He watched the same movie almost every day, The Bridges of Madison County. It didn't matter that he saw it the day before, because when he finished, he'd say, isn't she beautiful? He was talking about Meryl Streep. If you haven't seen the movie, it's worth seeing. Now, what about ethical implications? Aging-related issues, major challenge in ethics. First, truth-telling about dementia. There are still people, and I have people saying to me, don't tell them. And we've learned that that is not the way to do it. There are ways of telling, but you can't say, we're going to keep your secret. End of life, CPR, feeding issues, risk-taking. I mean, I had a family the other day in which the mother, who's quite demented, has quite serious dementia. The only thing she wants in life is return to her native home, which is Latin America. That's all she wants. She says, if I can't go there, I'm going to kill myself. Now, whether she can actually kill herself, I don't know. But the son showed me that she made an attempt to slit her wrist. He said, it only didn't work because she used a butter knife. But that's how it. So the question is it risky for her to go to her native? Well, it's an airplane ride. Can it be done? Of course. So how much risk you take depends on the situation and the degree of care provided by the province, individuals, novel medications, salvage therapy, like how many times are you going to treat one antibiotic for an infection after another? And then the whole issue of rites and rituals at the end of life. And depending on your background and your culture, there may be many things that people expect as part of their last days on earth. And some of these things are technological intervention. So then we have ethical implications, the role of institutions versus families, ability of families to absorb roles and costs. And I know that there are people all over, including at the Joint Center, which I'm sure if you asked each other, you're in that situation. Now, what about advanced care planning? Well, it became a whole industry. I mean, we were hiring people just to talk about advanced care planning, and they got very, very technical. And I found that it doesn't have to be technical. You don't have to make big spreadsheets, Excel sheets. Do you want this? Do you want that? You want to know what the values are. What are the values? What means to a person, I want to stay alive? It could be religious, and that's one thing. But it may be, if I could no longer recognize my family and taste ice cream and cheesecake, I want to go. Resource allocation. Well, how much as a society or as a family can you afford? Then the whole issue that's come up now is genetic profiling. We now have the ability to measure somebody's ApoE. And what happens if you do it? You do your ancestry, or not your ancestry, your DNA and all that. You find that you're double ApoE, and the insurance company says, oh, we're just raising your insurance premiums. Why? Well, now you have got a risk factor for disease. And then the whole idea of free clinical diagnosis and markers. And this is a very complex ethical issue at the societal level. Now, the idea of withholding the diagnosis, there have been a number of reports, but this is just one from almost a decade ago. Only 45% of people with Alzheimer's disease or the caregivers say they were told the diagnosis. Now, I can tell you, I'm now working at a memory clinic. You'd think that everybody who comes to a memory clinic knows why they're going to a memory clinic. Because why are they going anywhere? Well, sometimes they are told, but they don't understand because they don't really have insight. But I've had people screaming at the person who took them there because they accuse them of ganging up on them. And the worst part comes when I have to inform them that they shouldn't be, couldn't be, and won't be driving anymore. Because then they start looking at it as a conspiracy between their child and the doctor. I was accused recently of doing all this just to make money. Well, I can tell you, as a geriatrician, this is not enough for me to do what I'm doing. I do it because I love it. But the fact is, if you're not in the process of understanding what's going to happen, you can't be ready for all the things that may occur. And then, of course, the concept of non-maleficence versus autonomy. You want people to make decisions, but what if the decisions are bad? Are you allowed to make a bad decision if you understand it? Well, you are. You're allowed to refuse even life-saving treatment. So most of us recommend truth-telling. The challenge is not so much that you tell the truth as how you do it. And one of the things I've learned, it's always better, if possible, to do it in stages if you have that luxury. Now, what about a living will? Well, I mentioned it earlier. The living will speaks to the person who's the substitute decision maker, or the state's the proxy. It doesn't speak to the doctors, it speaks to so it has to be a discussion. Now, one of the problems is, can you anticipate the future sufficiently to fill out a grid advance directive? Now, we had that for a long time. I think the second director of the Joint Center had his own living will. It was a grid. If this happens and that happens and this happens, if you have a mild pneumonia but you can't walk, you want this. I mean, it was impossible. Nobody can anticipate it. But the important thing for those of us who do it is discussing the values. What does it mean for a person to say, I want to be kept alive. I want to be treated. Because trying to say, well, you've got a grade 2 heart murmur, you want to stay alive, but it's a grade 4, it becomes impossible. And the most important thing that I've learned is choosing the right SDM. You have to make sure the person who's acting on your behalf respects you enough to know that they must act on your behalf and not their wishes. And I've seen family members who basically say, I don't care what my mother said, I don't believe in it. And that always ended up with conflict. Now, what about weight loss? And this comes up in dementia a lot. Weight loss is part of dementia, especially in the later stages. Nutrition often becomes the focus of the family. They're losing weight. And we know that weight loss in the later stages dementia is a bad prognostic find. But it's not limited to late-stage dementia. And I see people who, for whatever reason, they often get worked up with this scan and this scope and that scope. And part of it is they lose their desire to eat, because eating, when you think of it, is more a psychological thing than hunger. I mean, we do have hunger, but most eating that's satisfying takes place among people. That's why we always go out to eat with people. And then we have aversive feeding behaviors. Sometimes that's related to global deficits, confusion, inattention, and sometimes loss of neuromuscular coordination, especially swallowing. Now, what's the consequences of weight loss? Decreased immunity, loss of muscle mass, loss of atrophy, functional decline, falls, fractures, skin atrophy, and for those who've been on the front lines, risk of ulcers, and it's a major risk for institutionalization. Now, sometimes you can intervene, but a time may arise when you can no longer take oral nutrition. And that's been explored by many very, very dedicated, knowledgeable people in the field, one of whom is Miriam Gillick, who's from Boston. And this she wrote long ago, 2000, almost 25 years ago, New England Journal. And although the purported benefits of artificial feeding, survival, aspiration, malnutrition, comfort, the most important is what the family says, we can't let him starve to death, because it sounds awful. And I can tell you, having looked after many people who were Holocaust survivors, it had a special power, because the family said, my mother was eating grass to survive, and now you're telling me we're not going to feed her? So the question is, what degree does the cognitively impaired person at the end of life actually sense hunger and thirst? Well, we can extrapolate data from the terminally ill cancer patients, and if you do the right things, not much. Now, I can tell you, for those of us who have fast days, I do it for religious reasons, not because I'm religious, but it's cultural. Every year I fast for Yom Kippur. And I can tell you that after a number of hours, you lose hunger because your body goes into a ketotic state. And ketosis is a very good anorexic. If you're ketotic, you don't feel like eating. So if you are not eating for a period of time, it's not as if you become starved. You don't feel that. But if you do good mouth care, then you don't have the suffering of a dry mouth. So what about other interventions to avoid harm, non-maleficence? Restraints, we have to be very careful about use of restraints. There's a whole issue about psychotropic medication because it's been mislabeled as a chemical restraint. It should not be used as a chemical restraint. It should be used to treat symptoms that are causing harm to the person, because I can tell you people who are actively hallucinating and delusional and fearful are suffering. And when you use the proper neuroleptics properly, it relieves a great deal of suffering. And the other one is aspiration. When you no longer have your swallowing reflex, we have to do things to try to avoid that harm. Now, what about the idea of autonomy? And I can tell you that having watched the evolution of ethics in North America, in my days of training in Scotland, there was no such thing as autonomy. You never asked anybody anything. It was wonderful. For a doctor, life was easy. Mrs. McGregor, tomorrow we're taking your leg off. Oh, thank you very much, doctor. I mean, they wouldn't even say why. You assume they knew why because they came in with a rotten leg. But then with the advent of the Beecham Childress Bible of Ethics, autonomy became the dominant, even though they said it shouldn't be the dominant principle. So having a sense of control over decision-making has now become a key component defining high-quality end-of-life care. And for those of you who know Peter Singer, he wrote a very important article on it in 1999. Now, he was the person who mentored me in terms of my getting my mentorship, my master's. So for active participants, you want to know they're informed, they respect their wishes, you have to communicate with them, you have to have the conversation, and substitute decision-making must be the understood role. And what about justice? We talk about justice all the time. And I often say to my students, so what's justice? And they think it's criminal justice. They don't understand the concept of distributive justice. And that's an important thing because we talk about it all the time. It's in the newspapers all the time. Can we afford? How come we have a doctor shortage? Why can't we afford to train another 100,000 doctors? Well, can we? With limited medical resources and questionable benefits, is tube feeding in advanced dementia justified? Think about it. If you keep somebody alive for another month who's not participating in life, who didn't even want it in the first place, at $1,000, $2,000 a day for a long-term care bed, what are you spending money on? Maybe you should spend money on childhood vaccinations. And we have different international practices. And depending on which country, and I've worked in a lot of countries because I studied overseas, and I could see how the different systems worked. Allocation of resources in a publicly funded system as opposed to a private system. I mean, if anybody saw the Tucker Carlson travesty of showing how wonderful the supermarkets were in Moscow, I said, what are you talking about? Do you know about resource allocation? I mean, did you go to a hospital there? I've trained and worked with many physicians who did their training in Russia, and they told me about it. Access to technology. If you live up in Sioux Lookout, do you have the same technologies as in Toronto? Well, of course not. But then you decide, how do you make it available? Now we do distance everything. I know places where you get immediate X-ray done and read 10 minutes later, 500 miles away, because that's where the center for reading, and now it's all digital. Attitudes towards death and dying, and cultural influences. Now, what about CPR? CPR is one of the most contentious introductions to medicine. And I can tell you, when I finished medical school, we didn't have such a thing. I arrived in Boston, my first night on call. I got called from the ICU, and the nurse said, there's somebody in ventricular fibrillation. I'm giving them of lidocaine. I said, lidocaine? Isn't that a local anesthetic? She said, oh, we've got a lot to learn here. And I saw really my first case of CPR when taken to the billing office in the hospital during orientation. Somebody was being presented with his bill, having been hospitalized, and they said it's because he saw the amount on the bill. He collapsed, he had a cardiac arrest, and the CPR team was called. And for 20 minutes, I watched dozens of feet of ECG paper going up, people bumping on him in this, and he died. Now, we may have some benefit to receive CPR quickly and have a reversible cause, such as an MI and arrhythmia, but in long-term care, the cause is usually multifactorial, and rather than being what we call a cardiac arrest, which implies it can be reversed, because everybody dies of a cardiac arrest, the heart stops, it's really death. So there's a long history. It was deemed when it first came out to be life-saving. The media depiction of CPR in ER and all those, dramatic and beneficial, fear of abandonment. The real outcomes in the frail elderly are very poor. And depending on the study, you might say almost nil. And much of the controversy of CPR is really ethics. That of autonomy. In other words, can you ask for CPR, even if it's not indicated? And we know there are many cases in Canada, some in Toronto, because physicians did not believe somebody should have CPR because of the illness, and the family said they deprived them, they were responsible for their death. And the case that was in March 2015, they sued the physician over a DNR order that was written by the physician outlining why CPR was not indicated in a 94-year-old person who said they want to be alive but had no chance of responding. So do you have to tell patients and the families what decision making? Of course. And you have to explain why. And what if the staff doesn't agree with this decision? Can people have whatever they want? Can people have treatments that are not considered useful or effective? We've had that. I've had people in Baycrest at rehab who wanted the doctors to provide them with all kinds of herbal and, things that we don't normally provide. You say you could do that at home, but if I prescribe it in the hospital, I have to say I know what it is and I'm responsible for it. Is there a role for a religious aspect? Are physicians obligated to provide treatments they feel will provide no benefit? Some court cases suggest yes, some no. And in the United States, it's a very big problem, not only in end of life, but of course, in abortion. If an arrest occurs without a DNR order, when should you do CPR? Well, only if it's a true cardiac arrest. That means it has to be witnessed and unexpected. Because if 2 minutes have passed, it's death. 3 minutes, 4 minutes. Well, a lot of people in long-term care are found dead. So you walk into a room at 2:00 in the morning and somebody has no vital signs. Do you have to call it a code? Well, nowadays with these new defibrillators, it's hard to escape being resuscitated, attempt, because they're all over the place. Now, in the right situation, they can be life-saving. And in the wrong situation, I feel that it's almost assault. So you have to explain to families that CPR has a very limited role at the end of life. And in frail elders, it is associated with traumas and indignities. And this is one of my favorite statements. CPR does not mean cardiopulmonary resurrection. You're not resurrecting people who are dead. If you are dead, you are dead. Now, what about the role of euthanasia, physician-assisted suicide? So we know about this now. It's been in European countries, gradual acceptance in many states, became legal in Canada in 2016. We now have track 1, which are pretty clear. You have to be over 18, death is predictable, person is suffering, all other options have been provided. Until the very end, MAID can be refused. And then track 2, which is much more complicated. And as a MAID assessor, which I am, I can tell you, track 1s are pretty straightforward. Everybody understands them. Track 2, because the person is informed of the means that are available to relieve their suffering, including palliative care, has serious incurable disability, is an advanced state of irreversible decline in capability, has enduring and intolerable physical or psychological suffering. The problem is, you can't anticipate when they're going to die. It may be like this for years. And it's very hard, I can tell you, as a physician, to say, I find it difficult to carry out medical assistance in dying in somebody who may have many years less. And they say, but my suffering is intolerable. And you say, well, your suffering is it really intolerable? I mean, that's a very subjective thing. I mean, I could go through a number of cases that would be helpful. And now, of course, we have the whole issue of whether it should be provided for people who only have a mental illness. And that's very complicated because I'm not even sure what a mental illness is anymore. And I treat a lot of people with so-called mental illnesses because we now know that every mental illness has a chemophysiological cause. Serotonin deficiency, acetylcholine deficiency. I mean, cholinesterase deficiency. These are all mediated by chemicals. In the same way that, in fact, blood pressure is mediated by chemicals. So why have we separated medical diseases from others? Just because there's a separate section of treatment that we call psychiatrists? No, psychiatrists obviously nowadays use a lot of drugs that work on a chemical template. Now, the fact that the person's expressing the disease in a emotional, psychological state, you could say, well, that's the same thing about people who've got carcinoma of the pancreas. They often get depressed. And their depression often doesn't respond to antidepressants because it's a somewhat different, although sometimes it does help. But the thing is, it's a big can of worms now because if you read the articles, one side or another, for and against, it's very controversial. So we can't do those provide MAID with, it was supposed to come through this year. It's been It says to be reviewed in 2002-4, but maybe not. And there are many physicians, including psychiatrists, who oppose expansion of MAID for those with a mental health condition. Is dementia a mental health disorder? Well, I don't know. It manifests itself with mental conditions. It's a neurological disorder. Trajectory of dementia is understood and predictable? No, not always. Can a person decide that they do not want to wait the expected trajectory of dementia to occur? You can't even do an advance directive for dementia easily. It's very complicated. Can a person with dementia have capacity? Well, of course, depends on the domain. Advanced directive for MAID, we don't have that yet. But maybe there should be, because you could certainly define the criteria for which point you say, when I am like this, even though at the time I can't say that I want MAID, if it's been deemed that I am at that stage, I would like MAID. And this exists in the Benelux countries, where really have been way ahead of us in terms of the implementation of assisted suicide. So in the 2015 study in the Netherlands, they actually found that there were some people who just said they don't want to live anymore. They didn't even have a label. Now, do you say, okay, if you don't want to live anymore, then we'll help you die? Or do you say, no, you don't want to live anymore? There's a 10-story building, go jump out of it. That's cruel. I mean, you could commit suicide for a nickel. I tell people, you buy a plastic bag, you take a good shot of Glenfiddich whiskey, you put the blood in a plastic bag and you die. But we don't like to do that. I mean, physicians, I've had somebody accuse me of being a murderer because I participated MAID, because he doesn't believe physicians should have any part of it. He thinks there should be licensed executioners. Well, we did that, remember? During the Crusades, during the Inquisition, we had licensed executions. So, during the late stages of disease that cause dementia, it is important to decide upon palliative care approaches, which includes the proper treatment of all symptoms, including restlessness, pain, and other discomforts. The use of appropriate medications, including opiates, should not be shunned by physicians using the fear of hastening death as the rationale, because it's shown that it isn't the case. And aging is the 21st century success story. The goal is to increase the quality, not just the quantity of life. Individuals with dementia who require long-term care present a special challenge, and this is especially the case as they enter the terminal phase of their condition. The challenge is to meet the needs of this and vulnerable population and their families in an acceptable, dignified, humane, and ethical manner. And I always like to quote, even though I can't find the quote anymore, I had it once and I lost it. And no matter how many times I've tried and I've had librarians look, I think it was paraphrased, but the essence is there. The lifespan of any civilization can be measured by the respect and care that is given to its elderly citizens, and those societies which treat the elderly with contempt have the seeds of their own destruction within them. And for those of you who are interested in reading anything that I wrote, these are 4 of my major books. There are older ones that are out of print. The one on the left, Parenting Your Parents, is coming out with a new 4th edition next month. This is 2 days to them now. Looking Through the Lens is an anthology of narratives, of articles I've written. Brooklyn Beginnings is a memoir. And Moments That Matter is ethical issues in elder care. Thank you very much. I'm open for questions.
Thank you so much, Dr. Gordon. That was a wonderfully thorough and incredible presentation outlining so much information, your wealth of knowledge. So we're so fortunate to have you. And I'm personally very excited. I will endorse, I'm not being paid for this, Dr. Gordon's books. I'm looking forward to Parenting Your Parents, the next edition.
Well, if I were in a group, I would ask them, because I've done this, how many sitting in the audience are involved with dealing with an aging relative? Everybody raises their hand.
Yeah.
Because it's either their parents or their grandparents.
Yeah. No, it's so
Right.
true. Absolutely. And I'm sure that's the case for those who are here today and people who will watch the recording. And so just for those who are online, if you do have a question, put it in the YouTube chat. But of course, if you aren't logged into YouTube or you want to ask a question anonymously, you can email that to jcb.ea@utoronto.ca. I think that email has been posted in the chat so that you can access that easily. So one question is in regard to a comment you made early on in the talk about how you treat an older person, that it's a reflection of the fabric of our society. And so what would you, based on your experiences, based on all of the work that you're doing, what would you say that our fabric in Canada is like?
Well, our fabric is a very mixed fabric. So, of course, we have the population fabric, which Canada being, as I take a lot of Ubers these days for various reasons, and every driver is an immigrant or a refugee. And I've met people from everywhere. And we always talk about Canada, what a wonderful country it is. And they give me all their experiences from wherever they came from, some horrid, and some, why did you leave Turkey? Because I was in a prison for 6 months and I'm Kurdish and I never recommend that to anybody. Why did you leave Afghanistan? They said, are you kidding? Why have you left Iran? I said, do you want to live in there? So all kinds of reasons. So different cultures come with different values. And one of the challenges in Canada, we have, in a sense, amalgamated our values based on some principles of Western liberal democracies. I mean, I go back to my Scottish roots, John Locke, and for those who've done their masters in ethics, these are some of the kind of core writers. So we've amalgamated, and if you look at the different policies across the country and how they've come, how did we get to legalizing MAID? I mean, the fact that it was already existing in the Netherlands and Belgium, and I visited there and I spoke to people, you have to look at their societies. You can understand, even though Belgium and the Netherlands have a mixed society also, religiously. And not everybody accepted it, but collectively they felt this was in keeping with the respect for autonomy that they valued. So you look at Canada and you say, well, when all is said and done, even though we have different movements, we agreed that the respect for autonomy of individuals matters. And therefore, we've integrated that into our cultural practice of medicine. I mean, the consent form, when you think about it, is the ultimate reflection of respect for autonomy. I can remember, because that's how I was trained. You never had to ask anybody. You just did it. And I have so many stories, if you want to read my book, of how many people would last. I mean, I would tell people things, because I thought they should be understanding. And they say, understood. They say, why are you telling me this? I said, because I think you should know. She says, I'm not the doctor. And I can tell you, having worked in situations where a lot of immigrant doctors from countries that have no concept of autonomy, they don't understand. Why are we speaking to the patients? Do they know what a surgery is? Just tell them they need surgery. So that's an important component of what goes into all the policies we have in aging, how we set up our healthcare system. I'll tell you, I was very ill and I was going to one of the big teaching hospitals in Toronto on a weekly basis to the Medical Day Center for chemotherapy. And I was absolutely happily impressed by the diversity of patients in that waiting room. This was a downtown hospital, and the whole spectrum of Toronto was there. Inner city, professional, doctors, homeless, in the same waiting room. And I believe they all got the same care, because people say, oh, well, you're the doctor. But I heard what the others were getting. You can hear through the, every door these days. So I think Canada, luckily for us, I believe, represents a very good amalgam of those values that we've inherited as part of our legacy. It's not perfect, but I think of the countries of the world, it's one of the better ones. That doesn't mean we should stop evolving. I think this thing with MAID for mental illness is a false paradigm. For those, and I've known a number of people who committed suicide, and it was horrible because they really should have had access to MAID, but they couldn't. Anyway.
Thank you for sharing all of your insights and your experiences. So appreciated. And I'm mindful of the time, but I do hope that maybe we can just do one more question even.
Yes, absolutely. I
Okay.
have time. If you have time, I have time.
Sounds good. We'll just recognizing I think I'm required to wrap up at some point, so I
Oh,
will.
well,
So I'll have to do that, just respecting what I'm required to do in the time that we're
okay.
here for. But a question came in just if you could comment on the report that very few people with dementia receive palliative care.
Yeah,
And then they're just speaking about, some behavioral issues, and it's
yeah,
not predictable like the
yeah,
sequelae of cancer.
yeah. I'll tell you, for example, the experience I have is when we started our palliative care program and unit at Baycrest, people with dementia weren't admitted. They were not deemed to be appropriate for palliative care. It was cancer, end stage heart disease, end stage lung disease, etc. But gradually, we started getting requests. And initially, and I know because I took it over administratively, my view was that's not suitable for palliative care. Palliative end stage dementia should be in long-term care. But people in long-term care said, we can't look after these people. We can't provide them with the care. So we gradually changed our admission criteria, and we set it up in a way that people with dementia and other conditions became acceptable. Now, one of the difficult ones is they have dementia and other medical conditions that they can't participate in getting treated because of their dementia, or they have severe behavioral problems that make it impossible for most long-term care facilities to look after them because they're not built for that. They're not built for it. So I would say towards the latter part of my tenure at the palliative care unit, I would say maybe a third, I might be off of my numbers, of patients actually came in with late stage, end stage, almost terminal stage dementia. And the biggest challenge is with families accepting as part of the symptom management, in addition to pain, we had to control behavior because they don't understand that having agitation and feeling attacked and paranoid is painful. They don't like feeling that there are people coming after them. And it took a lot of often in service to the family and support to show the benefits of actually using the proper medications. So it's a special challenge, and I think it'll be part of the palliative care spectrum. And I know there was an article recently that raised the question about terminal anorexia nervosa. Should that be in palliative care? And the argument made was, sure, for those who've treated people with end stage, I mean, you can't keep feeding them. What are you going to do? Have them permanently intubated and fed? They're going to stop anyway. So it's a very good question, very important.
Yeah, thank you so much. Lots of thank yous are coming in, unsurprisingly, Dr. Gordon. And
Oh,
yeah, and someone did just comment about just express appreciation that you pointed out that people with dementia do have some autonomy and
of
should be
course.
included in decision making. So certainly some comments
Oh,
acknowledging that appreciation.
no,
Um,
absolutely.
yeah, so no, and then there are some other, I would encourage actually folks, well, Dr. Gordon, I wonder if we can have you back. There are questions that are coming in.
Absolutely. I would be
Okay.
happy if you want. I mean, I've done this. I mean, since I had to sort of retire from Baycrest, I was ill. I miss the teaching, and I only do family medicine teaching once a month. But I love teaching. I love being involved. If you wanted to have a session that rather than me giving a talk, it was really a forum for questions, I'd be happy to do it.
I mean, personally, I have questions.
Yeah, yeah,
Other people have questions clearly.
yeah.
So I think that having some kind of opportunity to do that, given your knowledge, expertise, experience in this field would be very valuable. So let's explore that with the JCP. I
Okay.
think that would
Yeah,
be,
if you ask Jennifer, Jennifer and I finished our masters the same year,
there we go.
and
Well,
our theses, they used to be, there was a shelf that had all the theses next to each other because it was the same year.
that's fantastic. So I think that there will certainly be a place for you there. And yeah, no, I'm very personally grateful, and many
Okay.
others have expressed their gratitude just for you sharing all of your wisdom and expertise with us here. So let's certainly find a time to do that, Dr. Gordon. I
Sure.
think that will be
Yeah.
something that is well attended, and there are questions that I think will
Good.
still be very relevant and wanting
And
answers
and
to
I
that.
would like to find the time to talk to you vis-a-vis Bakers because the issue of I'll use the word religious medical ethics. I do Jewish. Shabir Alibi, when he was resident, we did Islamic, and then the person from St. Mike's, I don't remember who she was. We used to do a road show in which we would compare the different religious aspects of medical ethics, because they're more in common than different, but there are nuances that are different.
That sounds wonderful. I
Yeah.
would welcome that, and I think there's lots to discuss. So I
Yes.
will reluctantly, so that I can continue moderating some of these wonderful sessions, draw the
Yes.
seminar to a close,
Yeah.
and just highlight for folks who are here, who are watching this, that the next seminar will take place on March 13th, and that's the 15th annual Sue McCrae lecture, and that will feature
Yes.
Dr.
I
Yeah,
know.
which is great. Would highly
I,
recommend, and it will feature
I,
Dr. Christian
Sue,
Schultz.
Sue McCrae was one of my colleagues.
Oh, well, she is clearly still, yeah, well, obviously making an impact in this annual
Where,
lecture.
where is she?
So it will be, I'm not confident where she is now personally, but
Yeah.
she will often attend her annual lecture
Yeah.
because it is in honor of all of the work
Yeah.
that she's contributed
So
to our field.
what's the lecture on?
So the lecture is going to be featuring, it's Dr. Christian Schultz Quach, and he's going to be presenting with Margot Kennedy and Brendan Liver. They're discussing sexual and gender diversity in cancer care.
Right.
The PM Chosen Family Program. So this should be certainly something that folks would want to attend. I certainly will be. And just to note as well, of course, everyone who's here today probably knows that you can receive reminder emails and event
Yes.
digest emails from
Yeah.
the JCB if you email them
Yeah.
accordingly.
So I will look for that because I will do my best to attend.
Yeah, I think it'll be great. And Dr. Gordon, just thank you times a million for sharing all of your wisdom
My
with me.
pleasure.
This
My
was
pleasure.
wonderful.
Bye. Bye-bye.
Bye.